And I'm a Republican. So some of my perspective today will be clearly that of a Republican. But most of it's going to be kind of generic. Because some of you are Democrats, Independents, Republicans, and I thought that was more appropriate. Now, I will first say that I commonly say that being a gastroenterologist is great preparation for Washington, D.C. The same thing we deal with on a daily basis. Oh my gosh, just comes down like manna from heaven. Maybe that's not the way. And I'm commonly asked why run. My wife's a general surgeon, and she has that sort of general surgeon's kind of no-nonsense perspective on life. We're thinking about this, we're praying about this, people have approached us to run, we believe in what we're going to run about. And one morning we wake up, and we're about to make the decision, and she's got this look in her eyes, and I'm kind of hoping it's love. But there was no love there at all. It was all just a focus. And she said, healthcare is going to change over the next 4 to 8 years, and you want to be a part of it. And that's when we decided to run. Now, little did we know, it was not going to be 4 to 8 years, it was going to be our first term. But really the motivation that sent us to run has held us forth since. Whenever she's mad at me because I'm not home except on the weekends, I say, baby, you're the one that told me to run. Now, why is it important that we have positions there? Why would my wife, with her tremendous intellect and insight, tell me to do so? I was telling folks earlier that when I first got there, I went over and met I shouldn't say his name because we're being videoed. I went to meet a colleague on the other side of the aisle. And I said, colleague, you're a physician, I'm a physician. Tell me what it's like up here. He said, look around to all our fellow members of Congress. 95% of them do not know the difference between Medicaid and Medicare. And he goes, and I'm not making that up. Now that has changed, and in fairness, I don't know that much about the legal profession or about the real estate industry, but nonetheless I'm called to vote on them. So my colleagues in this past year or 2 years have learned, but that said, at baseline, what we in this room take as common knowledge is brand new to most of the folks who voted to redo 16% of our gross domestic product. Now that's a humbling thing, and frankly it calls for our involvement. Now I'm going to speak very quickly about policy issues because I'm actually on the program later on to discuss this more kind of at length. But just as examples of a way that our lives have been affected from this congressional term on out. Clearly, we've passed a huge health care bill, one that will reshape how we practice medicine. And I opposed it. There was two basic viewpoints on redoing healthcare. One is that if you expand access, you will lower costs. So people instead of going to the emergency room, they'll see a primary care physician, be referred for a colonoscopy, and we will have less cost because of the detected colon cancer. That was the bill that we passed. And the other bill is that if you lower cost, you expand access. Now, one is you expand access and you lower cost, and the other is you lower cost, you expand access. There's a key difference there. And we actually have empiric data as to what the answer, which is the best solution. Massachusetts, in a noble experiment, attempted to expand access on the idea that they would lower cost. And what Massachusetts has found is that when you expand access without a concerted effort to first lower cost, then you end up pricing healthcare out of the ability of small businesses to afford it. Right now, for a while, the governor was going to attempt to tell their nonprofit insurance companies that they could not raise their rates. They're nonprofits. They're not WellPoint or Aetna. They're nonprofits. And so they can't do this. But still, the New York Times had an editorial, this is instructive for us, talking about this issue. And it said that the reason that Massachusetts is having problems is because the providers charge too much. Okay. Now, we need to know that if Massachusetts healthcare is the beta version for what we just passed, and it has the principle that if you expand access, you will lower costs, but indeed we have found that as they expanded access, cost exploded. And the people who are influential in this line of thinking say, oh no, it would work. if only you did not charge so much. Remember that Far Side cartoon? One deer speaking to the other deer, and one deer has got a bullseye on his chest. And the first deer is saying to the second deer, bummer of a birthmark. When I saw that New York Times editorial that said that you and your colleagues and our hospitals are the problem because we charge too much, I thought to myself, bummer of a birthmark. Because that is a target that will be aimed upon going out as we see that costs explode under this plan, as they are predicted to explode. By the way, now Massachusetts is disenrolling people whom they formerly enrolled in state Medicaid because they cannot afford to cover them. There's similar anecdotes from California and from Arizona. That's the flip side, that if you lower cost, you expand access. The best example of that is a health savings account. I suspect many of you have a health savings account for your practice. In a health savings account, if the normal paradigm is you, through a course of a year, put up $15,000 for a family of 4 to purchase traditional insurance. At the end of the year, if you don't use the insurance, you put up another $15,000. With a health savings account, you sluice off some of the money, you put it into an account, and the person actually, if they don't spend the money, it rolls over till the next year. As it turns out, people who have a family of 4, the health savings account, their insurance costs are with a catastrophic policy on top. Their insurance costs are 30% lower than a family of 4 with a traditional insurance policy, 30% lower. They access preventive services just as frequently as the family of 4 with the traditional insurance policy. That 50% of the people with an HSA and catastrophic on top have family incomes of $50,000 or less, and that 27% of them were previously uninsured. Now, frankly, the empiric data is that if you lower cost, you expand access. 27% were previously uninsured, 50% have family incomes of $50,000 or less, and they're accessing their vaccinations, their colonoscopies, just as frequently as people with traditional insurance. Now, that argument fell upon deaf ears. So the other thing you learn in Washington is that Telfer Reynolds, my former professor at USC, could always either say overtly or obliquely, medicine is about truth. Among all of us at our best, we are about truth. If I have a deeply held belief that someone else comes up with a double-blind, randomized, controlled trial and shows me I'm wrong, I discard my prejudice and I gravitate towards truth. That's not Washington. Washington, you establish a position and you work backwards to support it. Now, it's a messy process, but as I come later to our role, your role, you have to be involved in establishing that policy position from whence you will work back to truth. It doesn't work the other way around, I hate to say.